Welcome everybody. I'd like to welcome everyone in the room and those online. And I'd like to give the word first to the President of the European Federation of Periodontology, Darko Bozic.
Oh, thank you, Nicola. So it is my great pleasure, ladies and gentlemen, dear friends, to host you here on this occasion that we have this actually wonderful piece of investigative and scientific journalism that has been conducted together with the European Federation of Periodontology and The Economist. And we are sure that this will have a huge global impact on spreading the words of the inequalities and of oral health around the globe. Having said that, we know that the recent data from the WHO from 1990 to 2019 actually tells us that we have 100% of increase in severe cases of periodontal disease globally, which actually puts not only period disease but also other chronic diseases such as caries from oral health really on a high level of importance for general health as well, not only of problems with the oral health and mastication and etc. So so we know that things are obviously, according to the data, not getting better for some reason. We really do not know why. But hopefully we will, in the next future, and maybe next 10, 20 years, we will be able to to take this back and go into direction where we want to go. Having said this, I know this presentation is going to take half an hour, so I don't want to waste time, and I want to let people that worked on this piece of evidence to present it to you, and I'm sure you will be surprised to see the results, and you will enjoy the results we can present. So, Nicola, are you the next one? So, Nicola, please, and thank you, everybody, for being here.
Thank you, Darko. This is the second Economist Impact white paper commissioned by the European Federation of Periodontology, looking at the inequalities on oral health. We have a brochure here for you, so please make sure you have one. It's entitled Time to Put Your Money Where Your Mouth Is. This report takes a new approach to the inequalities of oral health. We've taken the economic model on periodontitis from our first white paper, and we have also combined this with our economic model for caries to give an integrated report looking at the inequalities on oral health. We have examined the inequalities, we've looked at factors contributing to that unequal burden, and we have suggested opportunities for levelling up. I would like to thank the Economist Impact for conducting this work. I would like to thank Nigel Pitts for his expertise, his knowledge, his enthusiasm, and his attention to detail, really driving this project. I would like to thank Halion for their support. Without you, we couldn't have done this. I'd like to thank all the other experts, some of which are in the room today and some are online. I'd like to thank the Oral Health Platform for your collaboration and support. I'd like to thank the European Federation of Periodontology as well. Thank you all for helping us to raise awareness of the inequalities in oral health. I'd now like to pass the word to Professor Iain Chapple to put this research in context.
Thank you, Nicola. So, as Nicola sort of flagged, this is the second white paper by The Economist, and the first white paper was published in July of 2021, and that looked at the economic and societal impact of periodontal diseases. And it modelled prevention and the, if you like, the return on investment from preventative approaches to periodontal care, as well as traditional interventive approaches, which are more expensive. But what it demonstrated overall was that prevention, diagnosis and management of periodontitis is cost effective. It also made the case in the white paper itself that we need to see far better integration of medical and dental care systems, not just records, but early case detection, two-way referral, etc., etc. And it flagged the importance of public health campaigns, but on their own, without the individual public health attention, they don't work. We need both in parallel, one without the other. The societal without the individual public health campaigns doesn't work. And it really flagged for the first time the health inequalities agenda. It was huge. Those in the highest deprivation groups had by far the most periodontal diseases. In order to underpin the economic modelling for this particular piece of work, we developed a care pathway, if you like, as you can see here. And we start off with health, which can transition to gingivitis. This would be primordial prevention, as we heard in the platform presentation this morning. This would be primary prevention of periodontitis. These two are interchangeable. You can reverse this to this. So any interventions at those 2 points are preventive interventions. Whereas once the disease is diagnosed and we go through the various steps of treatment, then they are, if you like, surgical interventive procedures. They're much more expensive. So what the economists did was they modelled the direct costs plus the indirect costs, things like time away from work, etc., as well as intangible costs, impact on quality of life, years or days lost to disability, etc. And they did that across 5 scenarios. The baseline scenario was business as usual. That's the benchmark. And I just focus very briefly on scenario 3, which was an extreme positive scenario. Could we eliminate incident gingivitis? And if we could, what would the cost of that be? And this was focused on patient prevention at home. Again, as we heard this morning, this is professional education and training of patients towards self-care. And then if we could diagnose and manage 90% of cases of periodontitis, what would be the cost and the return on investment? And very, very briefly, the conclusions were, the economic analysis showed that both of those scenarios gave a positive return on investment, but by far the biggest return on investment was the preventive one, as in managing gingivitis, preventing new cases of gingivitis. And the sums were eye-watering. Across a 10-year period, they ranged in the Netherlands for just under 8 billion in cost reductions to 36 billion, as you can see there in Italy. And perhaps more importantly, if we neglect gingivitis and we don't pay attention to it, then not only do we see an increase in costs longer term, but we also see an increase, or a decrease, I should say, in healthy life years. So this was I think, I never say this, Nigel, but I think this was a harder care pathway model. We really needed Nigel's input on this. People say periodontal disease is complicated, don't understand it. Believe you me, when you see the model, it's complicated, and we have to thank Nigel for guiding us through that. And this is looking at direct costs as opposed to indirect and intangibles. It's purely the direct costs, and Moritz is going to explain that to you later, so I won't dwell on it. But we focused on the individual diseases because whilst they share common risk factors, they also have different risk factors. And so each model is pertinent to each disease, and the data and the outcomes are brought together in the white paper, as Nicola's just said, to give us an oral health measure. So really the research scope here was focused on inequalities of those 2 most common oral diseases, of periodontal disease and caries. And there was focus on the linkages, the common risk factors, and how we can address those. And as I've said, it was really very much about the direct costs of caries in the model. We looked at 6 different countries. We looked at 4 European countries, established economies, and we looked at Brazil and we looked at Indonesia. So that essentially what the economists gave was, if you like, a very broad and diverse group of countries with different healthcare systems, different population sizes, different per capita incomes, different structures, etc. And we then engaged in stakeholder involvement, and that was critical. We had a lot of stakeholders from across the spectrum of oral healthcare that provided feedback and input, and we also had an expert panel that gave us real insights into areas where the data wasn't present, because if data's missing, you can't model it. So the process followed was the same as for the first white paper. The economists did their own literature review. It's a completely independent piece of work. They engaged the experts. They then did their economic analysis, and that was all then brought together in the white paper that you see before you. And there is also a very nice infographic that goes with that. And these are the people I have to finish by thanking. These were the people who really provided their valuable insights through interviews. And we also had the expert engagement. This was the expert panel, who again were critical to the depth of understanding, particularly of the caries model. So I'm going to now stop and pass on to Moritz.
Thanks a lot, Iain, and welcome everybody. So Iain, you've just said the understanding of the model. So I've looked in detail at the about 500 people we have online and the composition of this group. So I understand not all of you are dentists. So maybe we'll take a short step back and just look at what we're looking at here. So we're dealing with oral diseases, and oral diseases have come a long way in the last 20 to 30 years from a communicable disease where you had to burn your toothbrush because you could give caries to your husband or to your partner, to non-communicable diseases, sorry, that is a tongue breaker. This is why we say NCDs, that are diseases that are driven by risk factors. And if you look at the stake of the problem in oral health, it's enormous. So we're looking at a combined burden of about 3.5 billion people worldwide. That's half of the population that is suffering from oral health problems. And Iain has been so kind to talk about our work on periodontitis, but there's a much bigger problem in the room. With a nod to Nigel, there's dental caries. And if you put those together and look at the other NCDs that we typically worry about in public health, on the other side, these are the 5th biggest ones, and their combined burden is smaller. So we have 1 billion less people suffering from these diseases than from oral health problems. So the aim of this project was to put together the 2 big diseases that are a problem for 50% of the world's population and to model them accordingly. One of the important problems with the NCDs is that they're driven by risk factors. And we'll see, also on the following slides, that these risk factors are paramount to the understanding, and they're common to several diseases, but also common to the more medical, non-oral diseases. So the big point here is that we have shared risk factors, but we do not have shared health provision, and we do not have shared education in many cases. So this is very, very separate. To be fair, I think it's fair to say that there's a siloed approach. Dental and oral health is very different in provision and in funding and in terms of education and resource allocation than the other diseases, even though they overlap so largely. And there's a very nice quote here saying that oral health could be understood as a canary in the coal mine, so the first one to go. So once you have a person that has these severe oral health problems, you wonder what else is there, how many risk factors do we have here in this patient, and how much more costly might these risk factors be in the end. Because oral health is something, as we will see, that is comparatively easy to prevent and to treat, comparatively easy. On the other hand, we also have something that is of utmost importance. We have an intricate relationship between the mouth, the mind, and the body. I would say the body and the mind, because that's secondary. The English make it very easy. They say perio causes everything. So gum disease will cause an awful lot of problems in the body, including a bidirectional relationship with diabetes, including cardiovascular disease, including, and that's a new thing, Alzheimer's and neurodegeneration. And there are secondary effects like problems with sleep and social anxiety or social problems that come with poor oral health. So we can summarize, we have a serious problem with oral health. It is largely periodontal disease and caries. They have overlapping risk factors, and these overlapping risk factors are possibly recognized but not treated together as they possibly should. As an additional complication, from a public health perspective, there is a very significant role of socioeconomic status of education in the population. So low education attainment will give you a lot more caries and a lot more periodontitis, and low income is associated with a 1/3 increased risk of caries prevalence. And in the end of the day, this means those patients will lose their teeth earlier. And that is a direct problem for all of us in the system. Taken together, this brings us an enormous burden. So we're looking at about 1/5 of 5% of global health expenditure in direct costs, and in other, let me go back, and another half of that, another 2.5% in additional expenditure for indirect effects. So this is a very significant amount of expenditure that is taken for oral diseases that are caries and periodontitis and the sequelae tooth loss. So what do we do with this? There is unfortunately a very significant lack of data. So yes, we do know that these two diseases exist. We do know that certain demographics have more caries problems, but we do not understand the consequences of this. And we particularly do not understand the consequences of this on economic factors in adults. So there's a lot more data, and we'll possibly discuss that later on, in children than in adults. So how did we approach this problem? We approached this problem by, again, putting up scenarios. And those scenarios were less complicated than the 5 scenarios you had in the Perio one. So we made it a bit easier, but it was also a much more complicated pathway. So one pathway could be the non-targeted interventions. So that means you target everybody with preventative interventions, everybody, be they the most deprived or the least deprived quintile in the population, and we would assume that their progression rates would decelerate by about 1/3. On the other hand, you might say, well, this is possibly the wrong way to look at everybody with the same measures. Maybe you need to put a little bit more individual thought into the specific situation of the person. And there we have the second scenario, that's the leveling up scenario. In that scenario, we're again looking at quintiles, so at groups from the most deprived to the least deprived. And the idea was to bring the caries progression rates of the most deprived down to the level of the least deprived. So to give additional consideration for those that are most at need. And in order to model that, we would need to have a quite complicated framework that I will guide you through now. So think of your teeth, these wonderful teeth that are healthy and fine and sound. If we do not look after them and we are exposed to risk factors, we will possibly come into the situation that our tooth surface substance demineralizes and we get initial disease. The beauty of it, like Iain pointed out in the gingivitis case, this is again a reversible situation. So there we still have the option to do something. However, if this progresses, we would get into the situation where we have decay, where we have a hole in the tooth. And if we don't do anything about it, this decay will progress and progress and progress. And in the end of the day, it will reach the dental nerve and you might need a root canal. That is costly and that comes with certain other issues. It may also not work. And if you then still don't do anything, you might be in the situation that this tooth is no longer salvageable. Interestingly, the pace of progression is shown to vary by deprivation quintile. So the more deprived, the faster they progress. And there are a couple of things we can do here. So we can do primarily preventative approaches in the areas where we have initial caries that is still reversible. We can have non-targeted interventions, like in our first model, that can approach everybody, where we can push down or decelerate the rates in everybody, but it may not be the best thing to do. And we have a quite costly and often repetitive so-called repair circle. This repair circle is what you know from the classical dentist: fillings, crowns, bridges, dentures, implants. And the more you do that, the more future work you will naturally occur. And this can become quite costly. And in the end of the day, if the tooth is too carious to be salvageable, you will possibly lose that tooth and go into an even more costly and more difficult repair circle, because you have not only to repair the tooth, but to replace the tooth. In order to model that, we have put together a framework where the different paces of progression and the different axes of people in different deprivation quintiles is modeled according to that caries progression conceptual framework. To start off with, we were tempted, at some point there was the discussion, we're tempted because there's fantastic data or better data to do that with children, but we wanted to focus on the permanent dentition. So we started with 12-year-old data as baseline. And unfortunately, as many of you will know, there is a certain paucity of good 12-year-old data. So we worked with the MFT data from Germany and also from Wales. The MFT is decayed, missing filled, and teeth. So a number that tells us how much caries problems we have. And this could be adjusted to the level of deprivation, and the size of the nation gave us very robust baseline values. And what came out of this analysis, we can now hear from our cariologist-in-chief, Professor Nigel Pitts. Nigel, the stage is all yours.
Thank you. So thank you very much for setting the scene, Moritz. I'll just share with you some of the results. The white paper, which I think you have, there are copies in the room, takes you through really quite extensive results. There's only time just to give you key results and a taste for what we found. As you've heard, we're focusing on two scenarios, and it's quite unusual, novel, perhaps the first time, that we've gone through a model that's looking at the variation in the progression of disease from 12 years old to 65. That's a sort of a life course approach, but the centre of the life course, adjusted by deprivation quintile. Because we want to look at the costs, want to understand the costs by those quintiles and the possibilities, the economic possibilities of the consequences of doing that. So as Moritz has said, scenario one, non-targeted interventions, and this is intervention agnostic. It's all the things you could possibly throw at caries prevention, upstream, midstream and downstream. It's not, this is the number for a particular favourite preventive approach. And it's also at 30% a conservative estimate, because we want to understand, this is an exploratory economic analysis, we want to understand what could happen here. Scenario two, which I'll share with you, which I think is the most interesting, is the levelling up or proportionate universalism approach, for those of you who like that word, where more attention is given to those in greatest need with the greatest burden. Now, this is perhaps a complicated table. I'll try and take you through it. It's the costs of caries per person in a population aged 20 to 65 years by the deprivation quintile in US dollars. We've got the least deprived at the top, second least deprived, middle deprived, going down the left-hand side, second most deprived and most deprived. And when we look at the economic burden, the cost of caries per person, you can see it's colour-coded from lowest to highest if you look at the key at the bottom. And in the UK, Italy, Brazil and France, the cost of the most deprived is highest. You'll see that Germany and Indonesia, for the least deprived, looks a bit out of step. And then if you go back for a moment to that model that Moritz showed you, the least deprived are the ones having more implants, more expensive restorative and more re-restorative care. So we have to be careful how we interpret those. But it's really useful across that range of countries to begin to understand these patterns, probably for the first time. Then I want to show you the results, and this is page 35 of the white paper if you're flicking through already, but I would commend you to go and look at the results section, because this is looked at by a number of different approaches. But this is, I think, the key slide. The non-targeted interventions trying to lower progression rates by 30%. If we look across those countries, UK, Germany, Italy, France, all of them are around 5,000 US dollars. That's the decrease in per person costs in US dollars. Brazil and Indonesia slightly lower, but you'll see apart from the least deprived, who are by definition a little strange, you've got a gradient there, which is exactly what you'd expect. So there is a benefit, and you can see the range of benefits in different countries, and the order of magnitude for two of the countries is about between $2,000 and $3,000, and for four of the countries, in the ballpark of $5,000. But if we now look at the levelling up approach, you'll see a rather different picture with dramatic maximum cost savings, decrease in cost per person for the most deprived groups. So particularly strong at around $15,000 for UK, Germany, Italy and France. You'd expect Brazil and Indonesia that are really quite different in terms of their scale, the disease, the presentation of the disease and the economic development to be different. But the one consistent feature across that right-hand side collection of data is that the least, if we look at the most deprived group, that cost saving, that benefit is 3 times bigger than the second most deprived groups in every country. So, levelling up approach looks like it could have very significant economic benefits. This is a quote from Wagner Marcenes, who's one of our experts. I'll take you through it. Oral health strategies need to prioritise preventive oral health and minimally invasive or interventive, choose your phrase, minimally invasive care. This is the only evidence-based approach to improve access to oral care and level the playing field whilst reducing costs to the healthcare system in the long term. And that's the perspective we're trying to look at. What's the cost to the system over time as this plays out again and again as people go through their dental lives? So now, back to Nicola. Towards levelling up the playing field.
Thank you, Nigel. So what are our key messages here from this research? We need to improve our estimates of early caries detection. We need to do this in order to be more successful with implementing our preventative programmes. Much of the research is based on DMFT, as Moritz has explained earlier on. And indeed, this model was based on DMFT. But we need to assess the early caries, and the DMFT has some severe limitations. It's easy to use, it's reproducible, but it doesn't pick up early caries, it picks up cavitation. Our experts have suggested that we need to therefore move away from DMFT, and we need to use other effective measures to allow for less invasive and more preventive care. We need to raise awareness and promote prevention and curb misinformation. We need to give the population, or engender the population, or empower the population with literature that they can easily understand and support that behaviour change. We need to get good oral habits from childhood all the way through adolescence and through that life course. And the best way to do that is for our parents to educate the child and do it right from the antenatal stage. We also need to produce good literature in easy format, easy readable format, in the right media. And I don't know about you, but my children seem to have learned to read by looking at YouTube. And we need to get this literature into the media that our children and our adolescents are reading. When we do that, we do have to be careful about also misinformation. And we have compelling evidence about fluoride. We've heard that this morning. One of the greatest public achievements in the 20th century. But there's still a lot of misinformation about fluoride and how it can damage our health. And we can see literature today about how it might cause brain damage, for example. Misinformation. So we need to think about that carefully. We need to move from a restorative model to a more preventative model with universal oral health care. Many oral health care professionals are still remunerated on this drilling and filling. And we need to change to different payment systems in order to better align with preventive care and reducing disease risk. There is a new pilot in France, the Oral Health Prevention Experiment, Expresso, so it's a fantastic name, that I think is worth following. This system includes a capitated remuneration and based on the risk of the patient to cover these preventative procedures. We have a quote here from Darko Bozic, and I believe Marco's online, and I will read it to you. Marco's one of our experts that was engaged in the Economist research. The payment model is a huge constraint. We're paying for treatment and surgical intervention. Until you start incentivizing prevention, you're not going to get a lot of results. We need to move towards value-based care payment models. We're not going to get out of this with the current payment model. We need to address inequities in access to oral health. If we look at the WHO figures, we know there's about 4 million oral health care professionals, 2.5 million dentists, but most of those, 80% of those dentists, are working in high or high middle income countries, and only 1.4% work in that lower social economic grouping. Several countries still do not mention access to dental care as a key pillar in their national plan for achieving universal oral health care coverage. And we know that less than 30% of the global population is covered by the universal health care coverage, which includes oral care. And of course, we're familiar with the oral health global action plan, about 75 global coverage targeted for essential oral health care by 2030. How are we going to do this? We need to expand and diversify our workforce. We have hygienists, dental health educators, we have our midwives and pharmacists, and we need to engage the patients at that point of care, right from a very early stage. We also need to be holistic, and we need to have joined up thinking. We need to have our dental records and our medical records joined up. We have SNOMED and SNODENT, but they really haven't got off the ground yet, although I know it's all being coded. We need to address the commercial determinants of health, and we heard about this morning. Better legislation to help protect our children and the population. Powerful corporations are involved in promoting products that are detrimental to oral health. We heard about tobacco and alcohol and refined foods and sugars. While the commercial determinants of health are primarily viewed negatively, industry stakeholders and commercial activity can play a key role in driving better health. So we need to engage in these partnerships, have a transdisciplinary approach. So we have our oral healthcare professionals, their representative bodies, the public health professionals, we have our oral care industry, and we have economists and policymakers. We need to come together and drive that better oral health. We also need to integrate oral care and care for NCDs, many of which have a shared risk factor, as again we heard in Moritz's presentation. We need to ensure that our medical students and our dental students are taught the same information in a holistic way. We need to make sure that skill and training focuses on the interlinkages of oral healthcare and the other NCDs. We need to ensure that our doctors are able to identify common oral diseases and then make the appropriate referrals. And we need to build capacity to assist people with oral healthcare problems and support oral health prevention and promotion. So joined up thinking. I'm going to close here with a quote from Kenneth Eaton. Thousands of older adults in care homes and hospitals are dying unnecessarily because their mouths aren't being cleaned. And he retells the story of a lady who had extremely bad arthritis. She broke her hip and was hospitalised. She did well from that operation, but her sight was poor and she wasn't able to clean her teeth while she was in hospital. The nursing staff also didn't clean her teeth and she died shortly afterwards from aspiration pneumonia. I'd also like to say thank you to Paula Vasallo, who's here today, who summed it up perfectly by saying there's no health without oral health. I love that quote. So what's the pathway forward? We need to engage the population by raising awareness. We need to address shared risk factors with other NCDs to improve overall health. We need to expand and diversify the oral health workforce. And I have to say, I was really pleased to see in the UK press that the government have just announced a 40% increase in training healthcare professionals by 2030. We need to incentivise preventive care, build public-private partnerships to promote population-level prevention, and we need to improve our methodologies to measure early caries and periodontal disease. We have the infographic, as Iain showed earlier. This is the Economist Impact website, if you'd like to go there and download any of the information. And of course, we have the EFP website as well. And we have a QR code if you want to take a photograph. And in the room, we have the brochures, so make sure you have one of these. I would like to thank the Economist Impact team. They're online today. I'd like to thank you, Gerard Dunleavy, and Rob Cook and Shivangi, who did the model, and also Julia Vina, who we worked with right at the beginning. I'd like to thank Professor Nigel Pitts, our expert cariologist, for all the work he has put into this project, a huge amount. I'd like to thank our experts, as I said, many of them in the room or online. I'd like to thank the Oral Health Platform again for their support and collaboration, our stakeholders, and all the work behind the scenes from the European Federation of Periodontology, particularly Sham Legendre and Candice Gasparin, who are at the back here, and Diego. Without them, we couldn't have done it. So our aim is to raise awareness, to promote prevention, and address those inequalities in oral health. Thank you. Now we have some questions that have come in online. Thank you for those. And of course, we'll open the floor to questions. Nigel and Moritz, would you like to come up to the stage, and then we can distribute as appropriate? And
so I hope Gerard Dunleavy, Gerard's done a phenomenal job with The Economist doing the modelling. Gerard's online for any technical questions that are beyond our comprehension. Perhaps if I start with two or three, yeah, there'll be a few of those. Perhaps to start with two or three of the online questions. How to overcome this is from Divya Das, how to overcome disparity faced by patients in oral health options and facilities due to their financial status. I think we would call that a big question. So I don't know who would like to... Gerard, you're online. Can we get an image of Gerard?
In which case I'll get out of the way of the screen.
Oh, here he is.
Here he is. Gerard, any thoughts as an economist on how we can address disparity based on financial status? It's really a public health question, but I would appreciate your view on it at least.
Yeah, I think from what we've got from the experts and the research, it's the multi-pronged approach. There isn't a single way to do it. There is, as the economic analysis shows, the most to gain from targeting interventions to those most in need. So I think using that as a motivation, but then also realizing that multiple actions are needed. You're going to need the education for across populations to have it in that easy way, to have prevention incentivized, to have availability and accessibility to oral home care. So I think it's really a range of actions that are needed, and that education coming in early. There's so many components to it. It's not a single action that's needed, but the multi-pronged approach that will help us reduce inequalities in oral care.
Thanks, Gerard. I mean, it is a big question, but we heard with the Oral Health Platform this morning, and Moritz, you flagged the oral health literacy agenda. It is huge, absolutely huge, particularly when you consider different languages. And that's something I think we really have to start focusing on and getting it into schools at a very, very early age. We have one here from Juliet Reeves, who's a hygienist I know well. She's done a lot of amazing research, actually. And her question is, how can we utilise the skills of the wider dental workforce, particularly dental hygienists, dental therapists and dental nurses in the prevention and treatment of these diseases? I'm going to kick off on that one. and say we need our French colleagues to make sure that dental hygienists become part of the workforce, because I know they're not in France, and certain other countries I know it's a big challenge. But certainly in the UK, we have a long history of dental hygienists. It's the same in the Netherlands and a number of other European countries, and they are a phenomenal part of the workforce because they're trained educators. So they really do get that prevention message across, they get the behaviour change across, and certainly their skills, and I think it's probably the same in the US actually, their skill sets are broadening and you know, year on year, and they're able to do more and more. And we now have therapists, and I know that other countries have therapists who can undertake basic restorations. Personally, I thought that was a retrograde step. I'd rather they went back to prevention.
Could I build on that?
Yep.
I think, as you imply, we've got to be very careful not to be one country centric. And the UK is magically different to practically everywhere else in the world. But across those 6 countries, the range of dental health professionals available is very, very different. So we've got to be careful not to just assume you can take one model that's funded and developed over 20, 30 years and plonk it into Indonesia or whatever. The other comment is hygienists in some countries are sharing with us that they feel very equipped to manage and be used to manage the perio side, but strangely less equipped to manage the caries side. There's interest in it, but actually there's not continuing encouragement from their employers and the postgraduate training. So I think we could deploy that resource where we've got it better across both caries and perio. And then the other thing, just in terms of widening the workforce, let's just not be too focused on dentistry and oral health. Nurses, midwives, pharmacists, there are other people out there who have contact with these people who are vulnerable and have a high burden, and they can either play a part. I think sometimes people say, oh, they can refer to the dentist. That's great if there is one. But they can also, at that point, do some of the prevention. So let's take a wider view, as it says in the report, about the range of healthcare staff. Not oral healthcare staff, but healthcare staff.
Can I just build on that, if I may? And Nigel, the midwives, you know, you've got the antenatal care, you've got that life right from the beginning where those parents can be informed with easy-to-read literature and build that prevention into that child's future.
Moritz, the situation
Yes,
with the nurses and the prophylaxis approach is an interesting one as well. Can you say a little bit more?
What I wanted to really emphasize here is what I said before on the silo that is dentistry rather than medicine, so that you have 2 aspects that are somehow miraculously divided in funding, in provision, often in research and also in education. So I think one of the ways, and I think Nigel, you pointed that out beautifully, is to go away from dentistry as a specialty to dental medicine, because it's a medical field and we're sharing all these risk factors for our NCDs. So if you want to address it, you need to address it from the start, and that is by looking at the risk factors, and that can be done by integrating dental medicine into other medical fields more closely.
I prefer the term oral medicine, but we know what you mean. That's an American term, isn't it, dental medicine? Because we're talking about the mouth in general, aren't we? Not just the teeth.
We're not talking about the British speciality.
Correct.
So just to confuse you, the FDI talk about preventive dental medicine as well.
There we go. We've got another one here. I think this is one for you, Nigel. Does the sponsorship of the FDI by sweets producing companies, this is from Jan Koch, have an impact on preventing momentum in the context with sugar taxes, etc.?
That's a very complicated question. The FDI, I know, has been being very self-reflective and self-critical in disentangling itself from various investments as well as relationships, and I think this continues to be on the table. There's also a conundrum about whether you should have encouraged sugar-free sweets, which might be better than the alternative, but might be socialising taking sweets. So I think the debate is live. It's a good point. Watch this space.
We have one probably for you, Gerard, here. What explains the high cost of caries treatment for well-off groups in Germany? Have the co-payments for better than standard care been included? I mean, Nigel alluded to potential reasons. Moritz, maybe first, and then Gerard's take.
Yeah, well, that is my German heritage. So the German system is special in a way that the costs that we have taken are actually from the yearbook. So they are real on-the-ground costs, not made-up costs. And they reflect also private health provision or mixed health provision. So what is actually being done? And it's a system where every single time you move your hand, you do something, you perform a procedure, is remunerated. That means that you will here see the cost of additional repair care, that is implants, that is indirect restoration, that is very fancy dental technology and high quality work that is being done on those who can afford it. That is not necessarily a bad thing. It just looks very odd on the table.
Gerard, any comments? Because Indonesia was another slight anomaly, wasn't it?
Yeah, no, I can add there just the variation in the provision of subsidized care within public systems within some of the countries. That was what those costs are within the health system. So it's not just the cost the patient is paying, but what is the cost to the overall system? That's part of the reason why we stuck with private costs across each country to use that as a proxy to estimate the direct costs of caries. And then in terms of Germany being an outlier in that aspect, so we looked at, our modeling assumed that the most deprived are more likely to receive an extraction or a less optimal lower cost replacement or no replacement at all, while the least deprived are more likely to get an implant after an extraction. And for UK, Italy, Brazil, and France, the cost of an implant relative to an extraction was between 12 and 35 times. And then for Germany, the ratio, the cost difference between an implant and extraction is 80 times. So that's why there was that outlier in the analysis.
That's interesting. Thank you. It's good to have the depth of insight on that one. I have one here from Spain, from Elena Navarro. What do you think the main factor why prevention doesn't work when it comes to avoiding gum disease, tooth decay and tooth loss? Which European country do you consider a model to follow in this respect? Well, I think prevention does work. I think what Elena is probably referring to is why can't we get it to work? And we were discussing this earlier on. I think it's partly down to our remuneration systems, which, like Germany, we have different iterations in different countries across Europe and the US, for that matter. You're paid to intervene. You don't get paid for prevention. And quite often, patients will go into a primary care dental practice, they'll have some excellent education and preventive advice, and they'll leave and say, well, that was a waste of time. I didn't have anything done. Whereas they won't do that with a family doctor. Philosophically, our model is still a surgical interventive model as opposed to a medical preventive model. And that's quite that's a challenge, I think, for the oral health platform. I'd have loved to have said it in the meeting this morning, is actually seeing or trying to encourage a shift in the payment systems towards prevention and away from intervention. Because, at the end of the day, dental practitioners and business people, they have to run a business and make a profit.
So if I can add to that, I'd take you back to that comment that was on the screen from Darko Bozic. We can't make progress towards a preventive route unless we change the payment system.
Yeah.
And I think that's entirely fair and a very good summary. And there's lots behind that statement. The other thing in terms of which country has done it well, from the caries side, caries risk doesn't go away. And governments have got a sort of a wonderful short-term, how long's the parliament? How long do I have to get voted in for view? Which, that's perfectly understandable. But if you look at, I would have said 10 years ago, Scandinavia, because we've got wonderful examples of wonderful prevention. So we've been so successful, we don't need any dentists, do we? The hygienists are doing it all, it's absolutely wonderful. Oh, migration. Well, nobody saw that coming. Oh, people are keeping their teeth longer, and suddenly the risk changes and a very well restored dentition falls apart and there's nobody left to restore it or re-restore it. So I think countries get caught, and the message to the politicians is that the sort of risk of oral diseases, but particularly caries, doesn't go away. So if your prevention works over a 5-year period, and it may be the case in Scotland, there's some very good, the Child Smile programme, which is an example of good practice for the platform. If you back off that prevention, guess what happens? It all comes back. So we've got to educate the profession, the public, and the politicians But this is a continuing long-term investment in prevention, not just a 5-year wonder.
So what you're saying is that in building incentives does work. I mean, we had so many quotes here. My favorite quote is actually from a person in business, Charlie Munger. He's always said, show me your incentives and I'll show you results. So if we want to go towards a preventative approach that is early and that is targeted, you need to build central incentives, and those incentives will be followed. So I think it is something that can be a way forward, that can also be a way forward for stakeholders and for politicians. I think there was a question from the audience, from our Greek colleague.
Thank you. My name is Dr. Aristomenes Sigelakis, Chief Dental Officer of Greece. I would like to congratulate you for great presentation and excellent work you have done. I have studied a lot the previous report, and this is very inspiring even for students and not only. I would like to ask you this. You have an estimate of the total oral health direct costs, about 4.9% of total health costs. This is really impressive. But is there any rough estimate of extra cost for health systems due to poor oral health? Is there any rough estimate how cost the unmet dental needs for health system because of the comorbidities and the complications? This, I think, it would be the decisive one element to make the decision makers to change their priorities and invest on health. Thank you very much.
I think that's a really good point. And the answer to your question is there is data. There's data from the US and there is now data from Europe on the comorbidity issue. And the figures vary according to what the comorbidity is. But the US data from memory, because it's a while ago now, and it's not a perfect study, it was one that the Jeff Coates produced, was around $5,000, I believe, per year in medical cost savings if you have type 2 diabetes. That's by treating periodontal disease. Don't know about caries, but you can imagine it would be added to that. And I think stroke was about $2,500 a year, and other serious adverse cardiovascular events were around about $3,500, I think, dollars a year. Adverse pregnancy was 5. So, I mean, and there is similar data coming out of Europe. It's a really good point because that will make healthcare funders sit up and listen. But that data comes from the insurance companies. It's really, really difficult to extrapolate that into the private sector and into publicly funded systems.
The other comment, I think it's a very good question, but in the caries world, these sorts of economic analysis and being able to produce figures for politicians and for the profession are just so stupidly scarce. We don't have the history and the tradition of having good health economic data, which is really shooting ourselves in the foot. So I hope this is a stimulus to people looking at the economic dimensions more closely across all of oral health.
I think it also makes the really strong case that Nicola alluded to of combining medical and dental records. The US insurance systems have those combined, and therefore they can look objectively at medical healthcare savings through dental interventions, albeit through a secondary analysis. I just want to read out a comment here from Tolulupe Osgabasan, I hope I've pronounced that correctly, who makes the point that since January of 2024, the FDI no longer accepts funds or sponsorship from sweet-producing companies.
So there you go. Instant update. I think we've got a Marco.
We have.
Marco, yeah. Marco, you're on screen.
Hi, thank you, and good morning from Chicago. I'd be very quick. Thanks for having me join here. I had a small part as an advisor in this, but I really just wanted to come on and congratulate you. So I'm the chief economist at the American Dental Association, and I lead the Health Policy Institute, which is a group of researchers. But I spent a lot of time studying the dental care market and specifically the economics of dental care. And this is just an amazing contribution. I want to underscore what Nigel just said. Simply having decent modeling, good analytics, the best we have based on the data, is extremely important in this area because, like it or not, more and more of the decision making within ministries of health, ministries of finance, etc., is going to need some type of economic modeling like this. That's just the reality. So I just wanted to say thank you. This is a major contribution. I love that it's actionable from the policy side as well. But more importantly, this is really going to help in making the case to a different set of stakeholders. Those that look at economic development, that want to create jobs, that look at the impact on academic outcomes, etc. This is just going to help make the case for why oral health is health. So thank you and congratulations.
Well, thank you, Marco, firstly for joining us from the Windy City and also for all of your expert advice and input. It's critically important for us to sense check. So thank you, that's very kind. Well, we may as well stick with the US because Chris Fox has posted something. Chris Fox, you will know from the IADR. Chris has said the report mentions the paucity of relevant data as a major limitation and calls for the collection of data with better epidemiological measures. How can we increase research funding to address these critical issues? Well, again, that came up this morning with the platform, didn't it? Anybody like to comment on that?
So I'll comment on it. Firstly, that's exactly what I would expect from Chris, and it's a very good question. But it's not just the research. The research going forward is fundamental, but it's the implementation of what we've known for 20 or 30 years, which is probably more embarrassing and just as important.
Well, I think the other thing that we're short on in oral health in general is patient-reported outcome measures. Because at the end of the day, we judge everything, or we have traditionally judged everything on our definition of success. Mm-hmm. That might be different to our patient definition of success. And we were discussing with the platform yesterday the potential for having patient or public involvement in the platform because they give a completely different perspective. And we have, in the British Society of Periodontology, we have a patient forum, and they really, really do open your eyes and ears when they come out completely left field with something you just hadn't thought about. And it's so valuable, really is so valuable. And George mentioned the need for PPIE, when you're writing grant applications and things, but that's very different to patient-reported outcome measures. And there's very little data in the dental literature, in the oral health literature on patient-reported outcome measures.
There was a lot of work which stalled about 5 years ago. Not quite sure why it stalled, but there's a lot of foundation work been done in that space.
Yeah, well, if you look at medicine, there are papers in Nature Medicine on patient-reported outcome measures. So, we're a little bit behind.
It's great we have, though, our patients feeding into our guidelines. So you'll be aware of the EFP guidelines. We've done a number of them, and we always have patients in there to help give their view, their expertise, and so we have consensus from both professionals, other stakeholders, but patients as well.
I mean, that's an important point because, yes, Iain, we are looking at what patients would love to see, but often that's quite difficult to measure. One of the biggest, I think, achievements the EFP has done was to link traditional dental measures, like measuring probing graft, etc., to what our patients think is relevant. And so we have a set of surrogate outcomes that work quite well with the priorities of our patients, so we can actually guide treatment decisions in a certain way. If we always were only focusing on patient-related outcomes, we would have some problems. But there is a new attempt we just discussed underway where we are actually running a PROMS workshop first that will then inform guideline development, so that treatment guidelines are actually based on an assessment what our patients care for, and only then we will do the literature research on clinical efficacy. So that is, I think, a new step into that direction.
The other thing that's not missing, but there is not a great deal of, is effectiveness data. We do all of our research studies in controlled environments, and you get efficacy data, but you don't necessarily get real-world effectiveness data. That's really hard to generate because you're talking about primary care practices that you have to engage in research and train them up in research. but they then can deliver real world evidence from the high street or wherever it is that they are working. That's another area that I think we need to see expanding in the future.
I'll just make a comment, if I may, as the strap lines on the screen. There's something implied with that. We do need to improve, we do need further research, but the data from this and much of the data that we've got for caries and periodontal disease shows the problem. And I think the strap line here, time to put your money where your mouth is, if we're going to address inequalities, we need to persuade people to invest and to pay for the right things and incentivize. So I just don't want to lose that action step and get lost in how we can spend the next 20 years improving the research by 5%.
So one last one from the tablet, then if there are any more from the floor. This is Thomas Madeir Cocker. So Thomas Cocker, right, okay. So if we look at time trends of oral epidemiological studies, we can see clear trends more towards more sound teeth. Probably this trend will continue. Was this trend incorporated into the model? I guess the answer to that question is no. Gerard, because actually that's not the way the model was set up and built.
And while Gerard's getting on screen, I'll just explain that one of the challenges which is listed in the limitations of the report and also the academic paper that's coming out of this work as well, is that with the estimates we've got, they're over a very broad time frame. So looking at shifts over time would imply that you need to have all the data for countries collected at the same time. Wouldn't it be nice if that was true and if the data was available? It's not. But Gerard, you can say it more eloquently than I can.
Thanks, Nigel. I don't know if I will, but I'll try. Thank you, Thomas. We did interview and you were very helpful in giving us a lot of information that helped to inform our analysis. We didn't get to incorporate that aspect. We did consider there was a lot of aspects that we would like to put into the model, but part of it was adding more limitations and assumptions. So for this analysis, we assumed a continuous linear progression in DMFT values, which simplifies the reality of how caries progresses over time. But we did base our data based on systematic review evidence of what is the annual progression of caries, and then we aggregated that so it was different across deprivation groups, but we couldn't account for potential changes that have been happening in the last 20 years. We did use the most recent 12-year-old data per country, so we were trying to use the latest data, but yeah, that is perhaps a limitation.
Actually, I should say that was Thomas Madeir Cocker, who's at the Karolinska. So, but nevertheless, thank you for your... No, that was my fault, Gerard. I must just give you some information. Christoph Ramsayer, who's based in Switzerland, says, thank you very much for continuing this excellent initiative. The financial relationship between oral health care and general medical care is key. After applying the Economist model to Switzerland, we estimated for our country a total of 17 Swiss francs cost benefit per hour spent with a dental hygienist. My question is, how do we move on from here? Incentives, I think Moritz said, but also building that workforce.
Incentives and the 6 steps that Nicola put on the screen and that you'll find in the report.
I'm going to stop taking questions from remotely now, but are there any questions or comments from the floor?
Thank you very much. First of all, I'm Dimna Kavanagh, and I very much welcome this presentation today, particularly the references to the work in the platform this morning at Parliament. And certainly this very much puts it into perspective, our need to get this message to our policy leaders in Europe and over the next 5 years, and change the impression of the benefits of prevention in oral health. I suppose one of my main question is, you're talking to the profession and to, I was going to say, not the converted, but to people at least who have an understanding of these issues within oral health. How about the public at large? I mean, how are we going to get the message? We talk about value, what, dentist value is incentivized, absolutely, financially. But how about the public? I think we've touched on some of that, but how can we get this message out to the public more clearly? Thank you.
Thanks, Dimna. Well, I'm looking at Steve Mason at the back. And if you look at The Economist and the comments that they made in the first white paper, they made the really important point that you, as well as individualized prevention, you need public health prevention, and you're not going to succeed unless you have both. How many governments will fund oral health campaigns? You're absolutely right. They're not going to do it. So we rely on our industry partners really to get the same healthcare messages out, perhaps a slightly different slant, but nevertheless the same healthcare messages out there. I would love to see, and maybe we can find some high net worth philanthropist who will fund a public health campaign around oral non-communicable diseases. Wouldn't that be incredible to get it out there in cinemas, on TVs? If there's anybody out there listening and you've got pots of money, please get in touch. We would love to help you spend it. But other comments? It's a really great question.
It's a great question, and I just want to highlight that it's a completely different conversation, and it's not scripted, hasn't been developed, and it needs to be. So that's one of the next steps. The other thing with the politicians and the profession, if you look in the literature, particularly on the caries side, but also in the oral health side, much of it has been focused on savings. Let's do a health economic analysis to find out how much we can save. Flip it the other way around, and there's quite a lot of policy development work saying, what's the value of a sound health state? Why is that more valuable to the patient? And so it's not just the cost savings from a preventive, stable, controlled, healthy mouth to all the range of benefits of oral health that Benoit listed this morning. It's the value to the patient. We haven't had that conversation with patients either.
Any further comments or questions from the floor before we draw things to a close, or before Nicola draws things to a close? Mr. President.
As the president.
Yeah, me again. Just like to, since I'm the president, the current one, and Moritz is in 2 months the next one of the EFP, I'd like to go back a little bit to severe periodontal disease. We're talking about caries, but just some of your thoughts, and maybe we can discuss a little bit about it. How do you see that there's such an increase in severe periodontal cases the last 30 years, in spite of all of the efforts we have done? Is it maybe more awareness, more diagnosed cases? Is it because people retain teeth more frequently? They don't extract due to caries, and that was much better. And then hence we have more periodontal disease, which is frequently really neglected in GP practices around. That's at least my opinion. So what do you think we could do to overcome this? And because in Europe we only have 34% increase in the last 30 years. Globally, there's more than 100% of increase in severe cases. So what can we do about that?
If you look at the paper, it's from the emerging countries, isn't it, and the increase in populations. So it's looking at those more deprived sectors.
Yeah, it's
where that data's coming from.
Yeah, it's multifactorial though, I think, Darko, as you've said. People are living longer, but actually people are choosing to retain their natural teeth for longer. And I think, the philosophy's changed. We discussed, again, at the platform, but also this morning, how, certainly in the UK, post-Second World War, your 21st birthday present was a full mouth clearance and a set of dentures. And we see these choices are starting to change. People are becoming more appearance aware, more aesthetically aware. There are impacts now recognised on mental health. So the functioning dentition has got to last for longer. I always say to my undergraduates, it's quite interesting when you think about it. We as humans, as animals, were designed probably to live for about 20 years, just past sexual maturity, so we can reproduce the population. And with improvements in public health and medicine, etc., we're living longer and longer and longer and longer. How many people lose their teeth from periodontitis before the age of 20 who don't have a syndrome? Nobody. Doesn't happen. So the teeth actually served us well when we arrived on this earth, but as we've seen improvements in public health and in medical care, the need to retain teeth has increased. But I think it's a really complex and multifactorial answer to your question, Darko, and I think you hit most of the boxes. But
yeah, I think it makes a point towards what you already said. The patient-reported outcome measures are what patients value, and there's actually some research on it. For from Germany, from the IQWiC, where they actually looked at what are your priorities as a patient. And the number one priority, with a lot of spare, was to keep teeth, to retain teeth in your mouth. They don't want an extraction on average and an implant. They want to keep their own teeth. And as you said, aesthetics or how well they function is even secondary to that. So you want to keep your teeth, and yes, it would be nice if they didn't hurt, if they looked okay and functioned well. But these are secondary considerations. So Darko will have more teeth to look after for the future. So there's a lot of work for the dental workforce.
So I'd like to say, I think this afternoon's launch has been very complimentary to this morning. I think I heard all our 6 key messages come up this morning in some form or discussion. And so I feel, I've really enjoyed today, and I hope you have too. What I'd like to say now is a huge thank you to Haleon. Without their support, that private-public engagement that we mentioned as one of our key ways forward, this wouldn't have happened. Steve Mason's in the room. Elle Newman has been very much engaged in working with us as well throughout this long project. And I'd also like to thank Heather Pellier, who isn't here today. But I really do appreciate your support, Steve, because this would never have happened without you. And I think we all agree that this is going to have big impact in the world, and a lot of people are going to use it for good purpose to raise awareness. I would like to thank you all for coming to this launch this afternoon. Thank you all online as well. We really appreciate your questions and your interest, and watch this space, I think we'll say, and safe journey home. Thank you.